Hi, good evening, everyone. My name is Elana Eisenreich. I'm currently a second-year medical student at SUNY Downstate College of Medicine and also a member of JOMA's Women's Health Committee. I wanted to thank everyone for taking time out of their busy schedules tonight to join us. We'll be first hearing from Dr. Bentley about labor and delivery, followed by a short Q&A. Feel free to submit questions either before Dr. Bentley begins or during her presentation, which we will try to address after. Dr. Bentley eagerly started her intro. I'll just sum up and she could obviously add anything she wants. Dr. Bentley is board certified OBGYN in Cedarhurst, New York. She received her medical degree from New York Medical College and completed her residency training at ICANN School of Medicine at Mount Sinai, South Nassau. She is passionate about obstetrics and takes a patient-centered approach to labor and delivery. Her practice, all women's OBGYN care, is well known for its low primary cesarean rates and successful vaginal birth after cesarean delivery rates. She also enjoys taking care of women at all stages of life and forming strong doctor-patient centered relationships.
There you go. That's me. All right, are we ready to start?
Yes.
Okie dokie, let's get to it. Okay, so let's start with the basics. What is labor? So labor is regular and painful uterine contractions that result in cervical dilation and effacement. Okay, when we think about labor, labor itself is really characterized by two phases. There's the latent phase, and that's everything in dilation up until 6 centimeters dilation, and then the active phase, and that starts at 6 centimeters dilation until what we say is fully dilated or complete, which is 10 centimeters of dilation. Labor in itself is also then further broken down into 3 stages. Stage 1 is that dilation, which is broken down into the 2 phases, and then there's stage 2, which is the pushing phase, and stage 3, which happens after delivery of the baby until delivery of the placenta. And you could see a little bit of pictograph right there. Okay, so what's induction of labor? So sometimes your doctor might recommend you undergo an induction of labor. An induction of labor is the administration of medication that facilitates uterine contractions that cause cervical ripening and dilation. Agents used in an induction of labor include prostaglandins like Cervidil, Cytotec, an intracervical balloon catheter, or Pitocin, which is a synthetic oxytocin. Okay, really which agent used is going to depend on your Bishop score on arrival. And we're going to talk a little bit about Bishop score in a moment. I just wanted to kind of show you what the induction agents look like. Cytotec itself comes in a couple forms. It's a pill that your doctor will either have you place in the cheek or will be placed vaginally. And it can also be broken down into a liquid form that's ingested orally as well. And then Cervidil is like a tape that's infused with the prostaglandin that is then placed behind the cervix and is left there usually for 12 hours. And in that time, cervical ripening occurs. And then a transcervical balloon or an intracervical Foley balloon catheter, there's a couple different kinds on the market. It's a catheter with a little balloon on the end, sometimes 2 balloons, and that helps mechanically dilate the cervix. And the mechanical dilation from the Foley catheter or the balloon catheter plus the prostaglandins work really well in the early stages of an induction to help ripen the cervix, which means like soften the cervix, kind of make it like, optimal for the start of labor. Okay, so again, induction of labor might be recommended due to certain medical conditions or if a certain amount of time has elapsed past your due date. Certain medical conditions that we routinely recommend induction of labor for include gestational diabetes, hypertensive disorders of pregnancy, so gestational hypertension, preeclampsia, fetal growth restriction. So if the baby's not growing appropriately for where you're at in your gestation, we may recommend that as well. Abnormal fluid levels, so if the amniotic fluid is too low or too high. Premature rupture of membranes, so if you break your water without the onset of contractions, especially if you have the group B strep bacteria that we screen for in the last trimester of pregnancy. If you have that, certainly at some point it's going to be recommended for you to undergo induction of labor or to help to facilitate those contractions. And then also in advanced ages, like over 40 years of age, because of the increased stillbirth risk, sometimes we also recommend induction of labor then too. Okay, so going back to that Bishop score, like I was talking to before, so a Bishop score less than 6 is considered an unfavorable cervix. And the way we calculate the Bishop score is using these 5 things. It's the dilation, so how many centimeters dilated is your cervix? Effacement, so that's how thick or thin your cervix is. Your cervix is like this long tubular structure, and with contractions, it goes from kind of really long to paper thin, and paper thin is 100%. So, during your like in the early stages of labor and all that, your effacement is going to go from 0%, and then to like your active labor is going to go, to 90%, 100%. Station. So that's how high or low the baby is in your pelvis. If you think about the outlet of the pelvis into the vagina or the birth canal, that's 0 station. So the baby goes from really high up in the pelvis to right at the outlet of the pelvis to into the birth canal or the vagina itself. And you go from -3 to +3. +3 is crowning. And when you're pushing, you're usually +1 station, +2 station, you make those kind of advancements. But usually early in the labor, you're a little bit higher, like -3 or -2. And then the consistency of the cervix, does it feel firm? So like you can almost, if you make a fist and you feel like that muscle here by your thumb, that's like what the cervix feels like at the start of, before you're even in labor or when you're not pregnant at all. It's kind of this like really firm consistency. And then it gets to like super duper soft and pliable. We look for that as well. And then the position of the cervix, is the position tucked all the way behind the baby's head where it's really, really hard to reach? Or is it more in the middle, or is it forward? As you progress in labor, as you dilate, the cervix comes forward more. So that kind of gives us a sense of where you're at, so we can help make the best decisions for you about how to start your induction, or even just to see where you're at when you come in for labor or an induction of labor. For induction of labor, like I said, if you have an unfavorable cervix with a Bishop score less than 6, we're really going to start with cervical ripening agents. So again, that's those the prostaglandins, Cytotec, Cervidil, and the mechanical dilator like the cervical Foley. And those work really well in conjunction with each other. But if you come in and you're already like 4 centimeters dilated and 70% effaced, we're already past the point of needing those cervical ripening agents. The cervix is already ripened and it's favorable. So at that point, we usually start oxytocin or the Pitocin, the synthetic oxytocin, through the IV, and artificial rupture membrane, so actually just breaking that bag of water. That works really well together. When you start the oxytocin or the Pitocin, you get regular contractions, strong contractions, and then by artificially breaking the water, the baby can descend nicely onto the cervix. And every time you have that contraction, the baby's head slowly, slowly pushes that cervix open. Okay, so let's talk a little bit about normal labor progress. There was a really, really big study done in 2010 by Zhang et al. They studied, they reviewed like thousands of records looking at the labor curve in women. And it was determined that a nullip woman, so that's somebody who's never been pregnant or never had a baby before, rather, I should say, the latent phase, so that time between 0 centimeters and 6 centimeters took approximately 16 hours. It was harder to define that in women who had already had babies because they tend to go quicker and there's a bigger range. And then the active phase, so 6 centimeters plus, that typically took about 1 centimeter. It took about, 2 hours for 1 centimeter of progress. Okay, so what happens if you're not progressing at the expected rate? We tend to call that protracted labor. So sometimes things stall and it's just not progressing at the expected rate. And then there can be labor arrest, where after a certain amount of time, there's been no cervical dilation despite attempts at augmentation. Okay, so we're going to talk a little bit more about that. To call a latent phase arrest, you have to really have been at least 12 to 18 hours with no change in the cervical dilation, okay, during that early phase of labor. However, 96% of women will enter the active phase after 15 hours. And remember, all of this is after, if somebody has stalled in labor, we try and assist by augmenting with Pitocin or breaking their water if their membranes were still intact. And by doing that, we're helping their body to dilate or to contract to actively assist with dilation. So at my institution, and it could differ at other institutions as well, we don't call a latent phase arrest until at least 15 to 18 hours ruptured, meaning having their waters broken, and on Pitocin. If after that point they still haven't made any change, then we call the arrest. But most women will enter the active phase if just given enough time to do so. And then an active phase arrest, so after you've already gotten to 6 centimeters, at that point, if you've not made any cervical dilation with at least 4 hours of adequate contractions can be monitored with an IUPC, which we'll talk about what that is in a second. But we use a standard called Montevideo units. That's what that MVUs means. And we use that to help guide us, or at least 6 hours with inadequate contractions. And again, that could be irregular contractions or contractions that are not monitored with an internal pressure catheter. And at our institution, we use 6 to 8 hours as the criteria to call that. So let's talk a little bit about, since we mentioned the monitoring, let's talk a little bit about external fetal monitoring so you know what I'm talking about. So there's 2 different ways you can monitor a woman in labor. There's the external monitors, so monitors that go physically on the belly, and there's internal monitors. External monitors, they come in a couple different forms. There's the ones that you see classically, like in the movies, the ones that are hooked up directly to a machine, and they're straps, and you're sitting in the bed and you're hooked up. And then now they have more, obviously with advancing technology, now they have Bluetooth wireless monitors. So this one here I'm showing you is the Novi monitor, and it's just stickers that they stick on the belly, and it monitors the fetal heart rate and the contraction pattern. So if you see here on the bottom, that strip, the top line is the baby's heart rate, and the bottom line is the contraction pattern, and each of those humps is a contraction, and between those 2 red bars is a minute. So we look at that strip over time to see how often is the patient contracting, how's the baby's heart rate doing, is it tolerating the contractions, etc. You may be required to have an internal monitor at some point if, again, you're not progressing at the expected rate, and we want to check your Montevideo units. That's the unit measurement that we use to determine the strength of a contraction, and the only way to determine the strength of a contraction is with that intrauterine pressure catheter. So it's just a very long, thin catheter that's placed inside the uterus. It goes right around the baby's head. And it can monitor the actual strength of the contraction. So we know that we're titrating the Pitocin to what you need, because every woman's going to need a little bit different. And then there's also something called a fetal scalp electrode. The fetal scalp electrode is used much less commonly. Really, the only indication for a fetal scalp electrode is if you're having a lot of difficulty monitoring continuously the fetal heart rate on external monitors. And it's just like a little wire electrode that you just attach to the baby's scalp, and then we remove it right before delivery. Okay, so again, let's talk a little bit. So things that impact normal labor progression. So why would some women progress normally and others won't? So things that impact that first baby, sometimes it's just hard. Your body hasn't done this before, your pelvis has never birthed a baby. So sometimes you just need a little more time, a little more patience. So those first babies can sometimes be a little bit frustrating. A big baby, so what they call large for gestational age, you may hear your doctor say that. That's a baby that's usually greater than the 90th percentile in weight overall. And that obviously a bigger baby is going to be a little bit harder to come out. It might take a little bit more time also. Obesity has been shown to impact normal labor progression, advanced maternal age. So sometimes the older you get, you might not progress as well. The position of the baby's head. So this is a really big one. And occiput posterior is probably the one of the biggest causes for failure to progress normally. And that's when the baby, you can see here in this picture, that's when the baby is facing, or sometimes it's called referred to as sunny side up. That's when the baby is facing the top of the pelvis with its face, whereas normally a baby should be looking towards the back side. Like when a baby comes out of the vagina, it's usually facing the butt. And the reason for that is because the diameter of the head is much smaller in that position compared to a face-up baby where it's much larger. So sometimes those babies just take a much longer time to come down through the birth canal because it's really like, it's almost like delivering a baby that's a pound bigger than its actual birth weight. And then cephalopelvic disproportion. This is just a kind of a phrase to describe that the baby itself just doesn't fit the pelvis. There are different types of pelvis shapes. Some are better for birthing than others. And there used to be, like, historically, doctors used to try and calculate the diameter and trying to determine if the patient was going to be a good candidate for vaginal delivery. We kind of realized that that's kind of all hocus pocus, and we don't have really a great way of determining who's going to have a successful vaginal delivery and who's not. So everybody gets a chance at a vaginal delivery, basically. But sometimes you do just see that when you do an exam, like, it may not feel like the best type of pelvis. And that could be why. Okay, I'm not going to go into spinning babies in all that depth because this in and of itself is like a full course on its own. But your nurses, your doula, your support person can help you if you are stalled in labor, and it is thought to be a position of the baby. Like, the issue is that the baby may not be in the optimal position. There are certain positions that you can assume during your labor to try and help rotate the baby into that optimal position, get the baby to descend and the cervix to dilate. So this is just showing you some of the positions. Really, it takes some skill to understand what position you think the baby's in, what position do we have to rotate it to, which way do you have to turn mom in order to get baby to rotate that way. So that's why it's like a whole course in and of itself. But there's definitely a lot of stuff that you can do in labor. So hope is not all lost if you feel like you're not progressing and you've stalled. And most, I would say, I mean, at least at our institution, a lot of the nurses are pretty well educated on spinning babies and the different types of positions to help try and facilitate baby's movement into the birth canal and out of the pelvis. And I would assume the same is true at other institutions as well. Okay, so let's talk a little bit about pain management, because obviously none of this is pain-free. I guess no pain, no gain, as they say. So things you can do before you, like, even before you talk about meds, there's a lot of non-pharmacologic options that you can use, especially, this is especially great in the early stages of labor, before you want to get an epidural, or if you decide you don't want to get an epidural, these are really good options that you have. Movement, obviously moving around and freedom of movement is really important. So sometimes your doctor, if you call your doctor and you say, hey, I started contracting, I think I'm in early labor. A lot of times I'll just tell my patients, stay at home as long as you can, because assuming, like, it was an uncomplicated pregnancy, there's no concerns about the delivery itself, no reason why they have to be at the hospital right away. I tell people stay at home as long as you can, because you can move, you can eat and drink, you're in the comfort of your own home. And those things really do help with progression early in labor, and also pain control early in labor. Hydrotherapy, that just means taking a bath, taking a shower. Some facilities have tubs where you can labor in the tub. Some allow you to labor in the shower because it really does make a difference. That warm water really helps. Hypnobirthing, that's a type of, so hypnobirthing is a type of like pain management. I don't even know what you would call it, but it's like a course you can take. There's books on it. There's classes on hypnobirthing. It's a lot of positive affirmations and associated with some types of breathing pattern, but a lot of really positive affirmations to help you get through labor. Pattern breathing, that's things like Lamaze. A lot of doulas, will teach you a different type of pattern breathing. And prenatal classes you could take that teach you pattern breathing to help you kind of cope with the pain of the contractions. Counter pressure, so actually just like some people like counter pressure on their hips when they're having a contraction. Some people like counter pressure like on their back or their tailbone, really depending on where the pain is mostly located. Touch and massage, I feel like that's kind of self-explanatory. Aromatherapy can actually help, and audio analgesia, that just means like, music, things that make you comfortable can help you get through the pain of labor. But then, of course, there's always pharmacologic options. There's always medications, especially for your first time. Labor can be really, really long. And, we all say you're not a martyr. You don't have to go through it with, an intense pain. And sometimes being in such intense pain can actually hinder your labor progression. Anxiety and all that kind of like being in fight or flight can actually like tense you up, and your body's thinking like, okay, this is not a safe place to birth. So it can actually hinder you a little bit in your dilation. So sometimes even just getting comfortable and being able to rest and relax and being in a better mind space can actually help you dilate. So things we have, IV narcotics, that's things like morphine, Stadol, you can get through your IV. The downside to those is obviously it can make you a little bit drowsy, a little bit loopy. IV sedatives like Benadryl, same thing. It doesn't take away the pain, but it can just kind of help you relax, especially if you feel like you're so tense and on edge in those early phases of labor. And those are really good for early phases of labor. Once you become more active, we're not going to offer you the like IV narcotics really anymore because you're getting too close to birth. Nitrous oxide. So this is a like 50-50 mix of nitrogen gas and oxygen gas. It's laughing gas. That's what it is. And it just, again, it doesn't take away the pain of labor, but it just helps you get through those contractions onto the next one, onto the next one. And some women find that really helpful. Then there's the epidural and the other neuroaxial anesthesia options like spinal block and combined spinal epidural. I'm going to talk about them in a little bit more detail in the next slide. Although I'm not an anesthesiologist, I'll explain to you a little bit about what those are. And then there's general anesthesia. General anesthesia is used only in emergent conditions, okay? General anesthesia means putting you to sleep. And it's usually only done in an emergency C-section where there's not enough time to get your epidural or your spinal. And we feel like we need to get the baby out now before we have time to do that. So rarely used, but sometimes is. So I put it here on the slide. So let's talk a little bit about neuroaxial anesthesia, kind of in a very basic sense. Epidural is the most common form. Spinal anesthesia is the kind that they use during C-section. So let's talk a little bit about the difference. Here's your spinal column, okay? Your vertebrae on the left. Your spinal column here with the nerves in yellow. Okay, they're broken down. There's a couple different spaces where in that spinal column, there's the epidural space and there's the intrathecal space. The intrathecal space is where your cerebrospinal fluid that cushions your nerves are and your nerves. And then right between that and like your muscle, tissue, fascia, and all that is the epidural space. So what the anesthesiologist does is they're going to place a needle through. And if you're having a spinal, it's going to go all the way through into the intrathecal space, and you're going to get a big dose of anesthesia that's just going to numb you from like the belly button down. It takes out sensory without the motor component usually, or just very light motor component. With a spinal, you don't get a catheter left in. It's just a big dose, and then usually you're going for a C-section. So then it'll last like 2 to 4 hours, and then it generally wears off. Because labor can take a lot longer than that, we have the epidural. So with the epidural, the anesthesiologist is going to put the needle in through the epidural space and then thread a catheter through that into the epidural space so that you can get a continuous infusion of those pain medications to last you basically from the time you get it until after birth. And that catheter actually stays in place. They'll tape it to your back. And there's a pump, and it's continuously infusing. It's continuously infusing those pain meds. Okay, so now we've gotten to the second stage of labor, right? Assuming everything's gone well, dilated, fully dilated, 10 centimeters dilated. Now it's time to push. According to the American College of OBGYNs, a reasonable time for pushing is 2 hours for patients who have previously had babies, and 3 hours for people who have not had babies. However, there's like a caveat to this. Assuming, or at least in my practice there is, assuming baby is doing well, mom is doing well, pushing well, there's progress being made. So we're actually seeing the head getting closer and closer and closer. It's okay to extend the time beyond that. However, this is really a guide for if the mom is pushing really, really well and baby's not budging. Like, we're pushing in every position you can see here. Like, I just put some examples here: squatting, using a rope to pull, hands and knees, on the back with the knees up. These are some of the most common positions that we use while pushing in labor and delivery. And as long as mom's pushing really, really well and baby's progressing, you can extend the time. But if there's really no descent, so baby's not coming down, we kind of use this as a way to say, okay, maybe it's time for a C-section. Like, unfortunately, can't just push forever. It would be very, very bad for your pelvic floor. But so we kind of use these timelines as a guide for us to assess, like, okay, is this baby going to come out vaginally, or do we have to think about an alternate route of delivery? But there is an alternate route of delivery if in certain conditions. So say you're pushing really well, baby's nice and low, but baby's heart rate is dropping, so we think baby's in a little bit of distress, or you've been pushing great for 3 hours, and baby is like right there, and you're just like, Dr. Bentley, get this baby out of me. I cannot push. Maybe I got one more in me, but I can't do it anymore. You have to pull this baby out. Now, most of the time, if it's me, I'll tell you, like, stop it. You're going to be fine. I'm here. Let's go. We're getting this baby out. But if you can see the effort is really starting to wane and mom is like really like miserable, we can talk about or offer operative vaginal delivery. There's 2 types. There's a vacuum assist. So that's where we put like a little suction cup on the baby's head and we give a pull. While you push, we pull, and the effort together helps get the baby out. And there's forceps assisted. So that's like these big metal tongs, and they wrap around baby's ears onto baby's cheek, and you kind of just guide baby's head out. There's obviously risks with this, which is why usually I'll tell my patients who are screaming, it's okay, we got time, you're good, you're doing it. But they're relatively minor risks. And obviously you have to weigh the risks versus the benefit of doing these types of operative vaginal deliveries. So with the vacuum, you can have scalp laceration, right? So you're putting that suction cup on baby's head. You can actually get like a little abrasion from where the suction was attached. Cephalohematoma, that just means like a big bruise can form. Imagine like putting a suction cup to your skin and pulling. So it's just like all the blood vessels kind of get like, pulled, and you can form a little bit of bruising in the scalp. And then less common, but also can happen, is retinal hemorrhage, where actually the blood vessels behind the baby's eyes and the retina of the eyes can bleed. And then with forceps assisted, the biggest risk is maternal trauma. You can have much worse tearing with a forceps assisted delivery compared to a vacuum. So speaking of tearing, let's talk about the different types of tears you can have or sustain during a vaginal delivery. You can have a vaginal laceration. So that's actually, let's see if you can see my, here we go. I don't know if you can see my mouse, but you can have a tear kind of right here at the entrance to the vagina, just going through the mucosa there. So just the top layer of skin, as you would say. Or you can have a sulcus. So these deep grooves or ridges in the vagina, those can tear. They can be really bloody. A labial tear. So these are your labia here. Okay. Obviously you can have a tear anywhere in the labia. Periurethral, that means kind of like right next to the urethra. This is the urethra. That's where you pee. You can have a little tear there. You can have periclitoral. So that's the clitoris over here. You can have a little bit of a tear over here. And then the most common is perineal. So that's kind of where we talk about when we talk about, oh, you had a 1st-degree laceration or a 2nd-degree laceration. We're all referring to perineal, and that's going between the vagina and the anus. Okay. A 1st degree is just going to go again through the vagina, but also including a little bit of the skin on the perineum. So the perineum is that stretch of skin right between the entrance to the vagina and the butt. So you can just have a little bit of the skin involvement. A 2nd degree is going to include some of these muscles here. So it's going to be a little bit deeper. And then a 3rd degree is going to go through just the sphincter muscle of the anus. So the outside, actually like what actually physically, like when you get that urge to go and you clench, that's that muscle. And then a 4th degree would actually be, and you can see that here in this picture, a 4th degree would actually be including the tissue of the rectum would have gone fully through vagina, perineum, muscles, and into the rectal. And that usually has to be, sometimes can be repaired in the labor and delivery room, sometimes have to be taken back to the operating room. And can cause some issues later down the line, but if it's repaired well, hopefully not. Okay, so what can you do to reduce your risk of laceration? Sometimes maybe nothing, but there is some evidence that suggests that doing at least twice weekly perineal massage starting around 35 to 36 weeks can reduce tearing in first-time moms. And it's kind of, this is just kind of, you can look up how to do that if you're interested in it. It's really just taking fingers with like a little bit of coconut oil or something and just gently massaging and stretching those tissues to help prepare it for birth, basically. And then the same thing can be done during labor, during pushing itself. Your provider can be doing perineal massages, warm compresses, especially right as baby is crowning, and perineal support while baby is crowning. So that's why we kind of take a hand and we put it right there. You can see that in that picture. She's holding right below the baby's head, right, kind of like covering the butt. And that's just to hold support so that it just doesn't, like the tissue just doesn't like split open real fast. We kind of like hold a little bit of pressure there to try and prevent that from happening. Okay, so what happens if you do get a laceration? The vagina heals remarkably well. At a 6-week postpartum visit, I literally almost, sometimes it's even hard to tell that somebody even had a baby. It's impressive. The vagina is fantastic like that. But during the first few days, weeks, it can be pretty sore. We recommend things like ibuprofen or other NSAIDs, and try to avoid opioids. Those are like those stronger pain meds that your doctor may send you because they can cause constipation, which can be kind of like rough after you just pushed out a baby with a tear down there. So that's why stool softeners and drinking a lot of water is really important. They sell Tux pads or witch hazel pads. They're these little like round pads that are infused with witch hazel. They're super duper cooling and soothing, especially if you pop them in the fridge and you take one out after every time you use the bathroom, you change it, you just put it right on. It's good for the tear, it's good for hemorrhoids. And then usually when you in the hospital itself, they'll give you some kind of like anesthetic cream or spray. It's like a lidocaine spray. It's just like a local anesthetic in an aerosol form to spray on if you have a lot of soreness. And then when you urinate, there are these things called peri bottles. You just fill them with a little cold water. And when you pee, especially if you have a lot of burning when you pee, you can squeeze the water on. And that'll help like reduce some of that discomfort. And then also afterwards for cleaning yourself, so you don't have to touch or wipe, you can just rinse it with water. Okay, so what are some reasons why we might suggest a C-section when you're in labor? So failure to dilate, again, if you have a rest in the latent phase or the active phase, and we've tried everything we could and something's just not right and you're just not dilating. So we may, counsel you that, hey, I think it's time for a C-section. Failure to descend. So again, if you've been pushing for that allotted amount of time and baby's just not coming down. Non-reassuring fetal heart tracing. So that means that baby's heart rate isn't tolerating labor. So there's some kind of decelerations that are concerning enough for us to recommend C-section. Most of the time, these can be resolved with stopping the offending agent, fixing the reason for the cause for the fetal distress. But sometimes even after doing that, if baby doesn't respond, we'll obviously, make a recommendation for C-section. And then if somebody has really super duper heavy bleeding in the early phases of labor, like if we suspect a placental abruption, which is when the placenta separates from the uterus itself, all those bleeding vessels that were feeding the placenta are now just bleeding, bleeding, bleeding. And if it's really early in labor and we're concerned about the amount of bleeding, we may recommend a C-section. A cord prolapse. So this is probably like the scariest and most traumatic way you can end up in a C-section during labor. And that's when the umbilical cord slips out in front of the baby's head. And you can see that's in that picture there, and slips into the vagina and is coming out first. And the reason this is an emergency is because that umbilical cord is what is supplying all the oxygen and blood supply to the baby. And every time you contract, that the baby is putting its pressure on that umbilical cord, and it's actually cutting off the blood supply. So if there's a cord prolapse dilated, usually the provider will keep their hand inside the vagina, and we're not just keeping our hand there, we're actually pushing baby's head up and elevating it off the umbilical cord to reduce that pressure so that baby is still getting that continuous oxygen. And then uterine rupture. These can happen in anybody, but is probably is what we counsel our patients who are trying for a vaginal birth after C-section. So if you've had a prior C-section and you're laboring, that scar is much weaker. And so that can actually open in labor. Now, sometimes it just opens a little bit and it doesn't cause any fetal distress. It doesn't cause any maternal issue. And we just watch it and monitor it, but sometimes it can catastrophically open and it bleeds and it's very dangerous, and baby can actually actually kind of end up in the belly outside of the uterus, and that's an emergency and has to be delivered right away. Okay, but why would maybe your doctor is saying you need a C-section even before the onset of labor? So that's what we call a scheduled C-section. And there's a lot of different reasons you could need a scheduled C-section, like breech presentation. At least in New York State for OB providers, almost universally, because of the increased risk with a breech vaginal delivery, we're going to recommend a C-section. If you have twins or higher order multiples, we might recommend a C-section, especially if one is not facing head down, or if you only have one placenta instead of two. Those can be much more trickier and much more risky to deliver vaginally if you have a placenta previa. So that's where the placenta is actually covering the cervix, where the baby should be coming through and the cervix should be dilating. The placenta is right there. And that can cause massive hemorrhage if you labor on a placenta previa. Vasoprevia, this is like a more rare condition, sometimes happens with a resolving previa, the umbilical cord can actually be crossing right over the cervix. And also, again, similar to like a cord prolapse, if that cord is right there in front of the cervix and cervix is dilating, the cord can, that umbilical cord can rupture and a baby can bleed out. The baby can actually kind of like compress the cord. So scary stuff, but don't worry, it's really not that common. If you come in with super duper high blood pressures that are hard to control with medications, if we've given you a lot of different medications and they're just not coming down, and you're not in labor, we may not have time to like start an induction of labor, or if you come in seizing, so that's what's called eclampsia. That's the like progression from preeclampsia. And that can also not always require a C-section, but certainly, again, if it's hard to control and maternal status is not looking good or baby's not looking good. So if you've had more than 2 prior C-sections, the uterine rupture rate is is much higher, and the risk is much higher after 2 prior C-sections. So after 2, we don't recommend VBAC. So we'll schedule your C-section. And then if you've had a prior uterine surgery, so that's actually a surgery that goes into the muscle of the uterus. So not like a D&C you may have had for a miscarriage or something like that. This is an actual surgery that, like I wrote here, myomectomy. That's where you remove fibroids from the uterus. You're actually cutting into the body of the muscle. And it's similar to C-sections. It's now you've created this defect in the uterine muscle that's much weaker and is much more likely to rupture during labor. Or just if you've had a history of a prior traumatic birth, say you've had a vaginal delivery in the past, but it was complicated by a really bad shoulder dystocia. And shoulder dystocia is where the baby's head comes out and then the shoulder gets stuck. And if it's really, really super hard to deliver, sometimes babies have like nerve injuries from them, or they can have like broken bones and stuff like that. And sometimes your doctor may say like, I don't want to do that again. And you may say, I don't want to do that again. And you say, okay, so, let's schedule a C-section. So there's always that. And of course, there's always elective. Some women just choose that for themselves. Okay. This is a really quick, let's see if it's even going to work. This is a really quick, I thought, you guys, we do C-sections all the time. So I think I'm just a little bit, used to what a C-section is, but this is, let's see here. Let me play it a little bit fast for you. This is, I don't know, can you?
The patient is 31 years old, about 40 weeks
Here we
into
go.
pregnancy.
Oops. What did I do? There we go. Wait, let's start again. Let's just play it back a little fast. Okay, here's a little bit about C-section.
The patient is 31 years old, about 40 weeks into pregnancy, and elected to have a cesarean section delivery procedure. The infant is positioned head down, facing the mother's right side. The patient is placed in a supine position with a drape screen set up. Working spinal or epidural anesthesia is administered. The procedure starts with a fan and steel incision, dividing the skin as well as the subcutaneous fat. The rectus fascia is exposed and is also divided. The rectus abdominis muscles can then be separated bluntly, revealing the peritoneum layer underneath. The peritoneal cavity is carefully entered, and the incision is extended along with the muscles. The lower uterine segment is exposed. The vesicouterine peritoneum is identified and divided sharply in order to mobilize the bladder off the lower uterine segment. Blunt dissection extends inferiorly. A valve for retractor is inserted to protect the bladder from injury. An incision is made on the uterine surface and developed bluntly until the infant's head can be seen. The infant's head is gently flexed and is lifted to the level of the skin incision, while fundal pressure is applied. The anterior shoulder is then delivered, followed by the remaining shoulder and torso. The infant is transferred to the care team after the cord is clamped and cut. A section of the cord is collected for analysis, and the placenta is delivered subsequently. The uterus is exteriorized for closure using 2 layers of sutures. The first layer is repaired using a locked continuous suture. The second layer is repaired in an imbricating fashion. The uterus is reintroduced into the abdomen, and the valve retractor, which is used to protect the bladder, is removed. The rectus fascia is closed with a continuous suture. The subcutaneous layer is closed, followed by skin closure.
Okay, so I thought that was kind of a nice, concise video on what a C-section actually is and what we're doing. How to take care of your C-section scars. So I would say, I think majority of doctors at this point are using what's called subcuticular closure, which is where you actually take a suture under the skin that dissolves and or even if it doesn't dissolve, maybe removed in the office, but is under the skin where you can't see it. And then I would say that's pretty like I would say most popular now, but you can close the skin with staples. That usually gets removed between 7 to 14 days after the C-section. That suture itself is going to dissolve within 2 to 8 weeks post-operatively, but sometimes, like I said, your doctor may try and take it out in the office when you go for your 1 week post-op check. The key point is to keep the incision clean and dry. Sometimes you'll go home with little pieces of tape on the incision to keep the edges of the incision together. Sometimes the nurses will give you little kind of alcohol swabs to swab the incision daily for the first 7 days. And that's really to try and prevent infection, to keep it clean. And you don't want it to get too moist. Some people keep a little maxi pad on it for the first week or so, just so that while it's those edges are really healing and coming together, any drainage is getting absorbed so that it's not too moist. Obviously, if you notice any new or worsening redness on the incision, if you have any weird drainage coming out of the incision, or any new kind of pain coming from the incision, it should be gradually getting better. So new or worsening pain is never, is usually not a good sign. So that's time to notify your provider. Some people do form keloids, or hypertrophic scars. That's kind of where the skin kind of puffs up a little bit and is a little bit less cosmetic. So there are things that your doctor can do to try and reduce that, like steroid injection. There are special kinds of tapes you can apply to the incision itself to try and reduce that and keep it nice and cosmetic looking. And then later down the road, there are C-section scar release, especially if you notice that you have a lot of pulling in from your scar tissue on the C-section scar itself. And usually some pelvic floor PTs are really good at this, teaching you the release and the massage of the C-section scar. That can be really good, but some people, it just depends. Everybody heals differently. Some people will heal really well and don't really require that. Other people form a ton of scar tissue, and that might be something that's good for them. All right, so that's my presentation. I think we have some questions here, but I'll let you.
Yes. Okay, so thank you so much, Dr. Bentley, for sharing your expertise with all of us. We really appreciate your time and effort that you put into this presentation. So now we'll be starting the Q&A portion of the webinar. So I'm just going to ask you a few questions. So our viewers wanted to know, is it still the common practice for women to give birth only on their back?
Okay, so like I said, I trained at South Nassau and I practice at South Nassau. So I don't want to say what's common practice because I don't know. I think it really depends on your provider and your hospital. But in my practice and a lot of the doctors here, it is not. However, that being said, some women I tell people, sometimes you just don't know. Sometimes the back ends up being the best position and the position where you're making the most progress. And sometimes that's just because when you're laying on your back, you feel a lot more pressure in your rectum. You have a lot more of that urge to push. And so sometimes that position ends up being the best just because, especially if you have an epidural, you can feel more in that position. And that really helps direct your pushing. But certainly for my patients who are not with epidural, most of the time they do not end up on their back. and feel quite uncomfortable on their back. So a lot of those patients will deliver on their side in a kind of hands and knees position on the bed. I've spoken to some providers at other institutions. Some institutions are not comfortable with patients delivering off the bed. So then it would be, you would be restricted to some kind of position that you could assume on the bed. But I'll deliver you in any position you want, as long as the baby is safe and I can access you safely and the baby safely. And we're not in a dangerous situation. I think we're moving away from the back position a lot more, and doing more physiologic birth, a lot more. And I think as long as it's done in a safe way and you're comfortable and your provider is comfortable, you definitely do not have to deliver on your back.
Okay, amazing. Thank you. So the next question is, what are the conditions or situations that can cause a woman to need stitches after birth? Or is it just a general thing that every woman gets stitches no matter what?
Okay. So, not every woman gets stitches no matter what. A lot of it is just your anatomy, genetics plays a role. Some people's tissue, the vaginal and the perineal tissue, and I'm talking, I want to say especially about your first time, because it does change after each subsequent birth. But with your first birth, it's really just going to depend upon your anatomy, your kind of your baseline anatomy and how your skin stretches. Some people have really, really tight perineal bands, and others, women's will stretch like butter. So there's not much you can do to kind of change how you're anatomically shaped and how your skin stretches and responds to that pressure, that change. But again, you can do things like the perineal massage. It can reduce about 30% of tearing or the degree of tearing that you have. But it is you do have to be dedicated and consistent with it. It's not like you can do a perineal massage one time and then expect to notice a change. You really have to do it every night or every other night for weeks. So, that there is that. But then after your first birth, that scar tissue, it always heals a little bit different, and your body changes, your pelvis changes, the anatomy changes a little bit. So we tend to see that with subsequent births, second, third, fourth, fifth, you usually do not tear as much as you did previously, if at all. So there is hope. If you tore really bad with your first, you do not have to assume that you're going to tear really bad with your second. A lot of times we see that the tearing gets much less in subsequent births.
Okay, thank you. For women who are Group B strep positive, how important is it for them to receive 2 doses of IV penicillin prior to delivery?
Okay, I think really just depends on how much time has elapsed between the time that the water was broken to delivery. Because a lot of patients will tell me oh, I'm so nervous. What if I show up to the hospital and I break my water and then I'm 9 centimeters dilated and I have to push? I'm not going to get that dose of penicillin. So I say in those cases, probably you're okay, because the time that elapsed from the time of breaking the water to delivery was so fast that the exposure to the Group B strep bacteria that the baby has is so minimal. It probably doesn't impose a big risk. The risk is really with prolonged exposure to the vaginal canal where that Group B strep bacteria is, and then it's super duper important. And when you break your water before labor even starts, you're definitely going to have kind of more time will elapse before delivery, and so then it is important. I mean, we don't just give antibiotics because we like giving extra medicine. Group B strep bacteria can be super duper harmful to the baby. So in those cases, it is important, but you don't have to worry. I think you don't have to worry so much if you break your water and then 10 minutes later you're delivered. It's, that exposure was super duper small. So there's a lot less risk there.
Okay, thank you. And for our last question, we had one viewer who said that she was super, super itchy from the epidural and she needed to turn it off, and she's not getting one again. What's the next best option? Nitrous oxide can help a little bit, question mark.
Yeah, so nitrous oxide again, it's not a painkiller. So I think when you go into, I think it's a great alternative though. Let me just say that. Like it's not a painkiller, but it is a fantastic alternative. Because if anybody's ever gotten laughing gas before, like during a wisdom tooth removal or like any kind of dental procedure, they can tell you like it really takes your mind away from like what's going on. And sometimes that's really all you need just to be able to get through to the next contraction, through to the next contraction. Now, being itchy from the epidural is a very common side effect. It's also something you can discuss with the anesthesiologist because certain anesthetics are worse for itching than others. So there may be something else you can substitute for that, but nitrous oxide is a fantastic alternative. The only issue is that it's not so widely used in the United States. It's really super popular in Europe. Our institution has it, but only just recently got it. And I'm not aware of any other hospitals in the like Long Island area that have it. So I think that is an excellent alternative to the epidural.
Hey, thank you again, Dr. Bentley, for your time. We hope everyone enjoyed, and we look forward to seeing you at our next webinar.
Okay, great.